Good morning to all of you. My talk is 8 minutes, approach to a patient with diplopia. So I just thought I'd be very, very brief and put out a couple of, this is the way I do it personally, so things may vary. So I'm going to divide this into a couple of things. So one is history in general and specifically history about the nature of the diplopia. The second part is more about the examination, the ocular motility, the lids, pupil, and don't forget there are other structures around like the orbit, paranasal sinus, and of course the CNS itself. Number 6 is of course the imaging, and last is how do you manage the diplopia. So let me just go through the history quickly. Apart from the diplopia, please remember, depending on how patients present to you, whether it's in a ward or in your office, are there any focal neurological deficits? What about general things like cognition, things like headache, etc., which you need to keep in mind? Pain is very important. The presence of pain with diplopia, whether it's a periorbital pain or a periocular pain, the presence of headache, what kind of headache it is. Orbit and PNS, generally we forget about it, but please do remember it. Orbit signs may not be very prominent, they may be subtle, but it's up to us to pick it up. And of course, general factors like risk factors like diabetes, hypertension, hypercholesterolemia, etc. But apart from that, giant cell arthritis is something you need to remember. And my nightmare, my scary thing is uncontrolled diabetes in the presence of cranial nerve palsy. Is it mucormycosis, for example, which can be very fatal. Secondly, about the specific nature of the diplopia, I think if you ask even these questions and elicit patient answers to these, you will probably even end up diagnosing which muscle is involved. So if it's monocular or binocular, that will tell you whether the cause is intraocular or extraocular motility related. Are the images separated horizontal or vertically, which tells you what kind of muscles are involved. Which direction is it worse? If it's on left gaze, it's about the muscles relating to left gaze. If it's a divergence is more than convergence, then you're thinking of a sixth nerve palsy. Is the diplopia crossed or uncrossed, which will tell you whether the eye is exo or eso, because these may sometimes be very apparent to you, but sometimes they may be subtle. So asking these questions and doing the simple things is very helpful. And of course, last but not the least, is it variable? So everyone knows about myasthenia gravis, but thyroid ophthalmopathy can also present with variable diplopia. Right, then we go on to our examination and we are looking at our ocular motility, and just to be brief, this is the things I am looking for. 3, 4 and 6, is it isolated or combined, multiple cranial nerve palsy? Look at the pupil, are you looking, is it anisochoric, etc.? Are you looking at a third nerve palsy, or the presence of Horner syndrome is also important to us. The other cranial nerves apart from 3, 4 and 6, which could be the optic nerve, the 5th, the 7th and the 8th. So this entire constellation from 2 to 8 will also help us in helping with the diagnosis. And of course, please remember there are supranuclear patterns which one can also pick up. So very quickly, third nerve, I think everyone has seen. Fourth nerve, here is this kid with a left hypertropia, and you do the 3-step test, and you can see that the hypertropia is worse on the right gaze, and it is also going to be worse on the left head tilt. So here is the right head tilt, which is fine. The left head tilt shows that upshoot, telling us that this is a superior oblique palsy on the left side. Okay. However, this kind of movement you cannot do if there is a presence of a third nerve palsy as well. So how do we make out fourth nerve palsy in a third nerve palsy patient? So you can't look at the depressing effect of the superior oblique. We look at the intorting effect. This is a patient who has had a peribulbar block and all the recti are kind of blocked. So here very clearly you can see the intorting effect of the superior oblique. When she looks down, here you can see that very clearly. This is the kind of movement we need you to see in the eye kept in the abducted position. Ask the patient to look from up to down and look for this intorting effect, and that will tell you whether the fourth nerve is intact or not in a third nerve palsy. Please also remember restrictive palsies, variability, as in myasthenia or TED, orbital fractures, myopathies, and occasionally Duane's type 1 can also produce a little bit of diplopia as well. The saccadic speed is also important. This is a lady who had a right third nerve palsy with ptosis. Her fourth nerve was also affected. But here I want you to see the abduction in the right eye. And if you see it in slow motion, it's even clearer. You see how quickly the left eye adducts and the right eye is still moving so gradually. This is a slow saccade, an abduction saccade, which is significant because it tells you that the sixth nerve is also affected. Lids and pupil, as far as lids are concerned, is there ptosis or lid retraction, the presence of fatigue sign, and of course lid gaze dyskinesias. Here we are holding up the lid and looking at it, and sometimes when you do this, you can actually miss a couple of things. So here's what you can miss. So look at the lid there. When she looks down, the lid retracts. Okay, the left lid retracts. There you go. The left lid also retracts when she looks inwards. Okay, an adduction, you can see that. So this is an aberrant regeneration of the third nerve. It can happen in trauma and compressive lesions, but definitely not in an ischemic nerve palsy. The other picture shows you the pupil. Look for anisocoria. Here is a patient who had trauma. The right pupil is there for your just for visualization. See the size of the left pupil between adduction and abduction, and you can see this constriction when the eye is adducting. So this is a pupil gaze dyskinesia. So that's also significant. Orbit PNS and central nervous system. So please remember, uncontrolled diabetes mellitus in cranial nerve palsy. Do not forget the possibility of mucor. Imaging, everyone knows MRI with MR angiography is important. I would definitely do it for any case of third nerve palsy or isolated sixth nerve palsy. Fourth nerve, depending on the history, I reserve my judgment there. Obviously, any case with multiple cranial nerve palsies or dyskinesias, any patient with a cranial nerve palsy with CNS involvement or Horner's or orbital signs as well. Okay, so that's a patient with dissection there, carotid dissection with neck manipulation. Management is very quickly, so I'm not going to waste too much time on this. My time is running out. But importantly, I want to talk about dangerous diplopias. So in a pupil involved third nerve palsy, we'll be looking at aneurysms. As far as painful ophthalmoplegia with orbit signs, we could think of Tolosa-Hunt or mucormycosis. Multiple cranial nerve palsies, neuropathies, think of orbit, cavernous sinus, and the skull base. If you have a cranial nerve palsy with either lid or pupil or eye movement, then you can think about, is it Horner's? If it's with a small pupil, but if it's with a big pupil with ptosis, it could be aneurysm. Variability, you know, myasthenia gravis. Don't forget that myasthenia can have serious generalized issues as well, including respiratory issues as well. And any new onset headache, scalp tenderness, pain, or swallowing, not only aneurysm, but you can also think of temporal arteritis. So with that, I'll just close and we can open for discussion.
Thank you, sir. Any comment that you would like to?
Yeah, excellent talk, and I think right now where Indian neuroophthalmology is there, neuroimaging in cranial nerve palsies, as even Sir said, especially third cranial nerve palsy and sixth nerve palsy, it's kind of becoming a must because of the a few horror story cases that he shared, especially in diabetics. Especially in diabetics.
Yeah, I think one should always make an attempt to, you know.
Fourth nerve, you said that you will reserve your this thing. I think it's in trauma.
Because fourth nerve is usually, it could be a congenital or sometimes it's a post-traumatic fourth nerve. And congenital can happen in much later in life because of a decompensation of a foria. So there are ways you can diagnose that, look at old photographs, etc. So, and in diabetics, I generally prefer to follow them up, but please remember, whichever cranial nerve palsy you're following up and not doing an imaging, it's good to follow them up very frequently in case untoward other cranial nerves start getting involved or there's something is getting worse then you know you're not dealing with a diabetic fourth nerve palsy. It's something else.
Right.
And I think it's important to keep that in mind if you're not imaging at the outset. Okay. And I think MRI with MRA is useful. In fact, I had a word with our radiologist. I said, what about if it's too expensive? Can we at least just do a CT angio? Will that be less expensive? And she actually said it's not really, it's almost the same cost. So I think between the two, we might as well do, and it's you don't need to worry about injecting contrast and things like that. So I think just doing an MRI with A would be the best thing.
Right. Thank you. So we move from the yes.
The MR, I think there are radiologists who just do cranial, who just do CNS, the neuroradiologists. One needs to have a good communication with them, because unless you tell them what to look for, they might miss it. They might be very subtle lesions, and it's not the fault of radiologists. Again, it comes back to I see what mine knows. So if you're looking for it, you might find it, which otherwise can be missed.